Hi, my name is Sarah. I'm here to make a presentation for my final DNP project, reducing readmission rates using revised discharge guidelines. Just a brief introduction about alcohol use. Alcohol use disorder contributes to about 5.1% of the total global burden of disease. 3.3 million deaths occur each year globally, which results in substantial costs to individuals and the society. At Maryland Treatment Center, many patients are admitted more than 3-4 times each in one month, confirming the high burden of AUD. There is great need to explore ways to reduce readmission rates. Just a brief background, the burden of AUD in the US is about 7.4. Readmission rates in detox facilities in the US ranges between 11 to 18. At Maryland Treatment Center, this rate is higher than that. It's about 20%. It has been reported that readmission rates is an important indicator of quality of care. One way reported to reduce readmission rates is through continuity of care to the communities after discharge. This project used the revised discharge guidelines to reinforce continuity of care. Readmission rates are used as an indicator for quality of care in many health facilities. And high readmission rates indicate the burden of addiction. Inadequate health care it also indicates inadequate health care in these facilities and indicates deficient performance in alcohol substance disorder, in alcohol use disorder. It contributes significantly to the increasing burden of substance use, causing significant financial burden to the hospitals, communities, individuals who spend a lot of time coming to hospitals instead of sitting home or working or taking care of their families. So readmission rates are criteria for ranking performance, which involves putting financial penalties to poor performing hospitals. It is therefore important that hospitals and healthcare facilities leaders devise visible means of lowering readmission rates to improve patient and institutional outcomes. Prior studies have emphasized continuity of care as an important aspect in reducing readmission rates. That's why this project focused on continuity of care through discharge guidelines. The main purpose of this project was to determine the role of revised discharge guidelines in reducing readmission rates in a detox facility within 3 months. The overall aim was to improve quality of care among individuals with alcohol use disorder. This project has important significance to nursing. It contributes to the 5 patterns of knowing. For example, it contributes to empiric knowing because it's based on evidence-based knowledge. It contributes to ethical knowing because it has respect for human dignity and it was based on professional ethics. It contributes to emancipatory knowing because nurses use emancipatory knowing to advocate for health and quality of life. It contributes to personal knowing because it involves self-reflection on the part of the nurses before they can start advocating for the patients. It contributes to aesthetic knowing because nurses are creative as they give the education, as they give discharge learning to the patients, discharge teaching. Even if you see 2 patients with the same discharge guideline, you're going to be creative on how to talk to each patient depending on the presentation. So it contributes to aesthetic knowing. The significance to healthcare, it explores ways to improve hospital and patient outcomes. It bridges the gap between community and hospital services. It reduces costs for hospitals and for patients, and it adds to new knowledge. This project got support from the facility, from Maryland Treatment Center. It got moral support from the managers and the facility staff. There were many committed nurses, social workers, counselors, and providers who supported the project. The hospital equipment was used at no cost. The scholar was able to access the computers, the printers, the space, and access the hospital anytime that the scholar wanted to access the discharge papers. And main support also from Maryville faculty, who tirelessly made sure that the study was adhered to the guidelines. In the literature review, Maryville University Library was the main source, using databases of Sinao, Medline, Cochrane. The search criteria was used looking for peer-reviewed articles which were in English and complete, published between 1999 January and December 2022. The initial search using keywords, which I will not mention one by one. Some of them were alcohol use disorder, alcohol addiction treatment, abstinence from alcohol. The list was long. It yielded over 800 studies. These were narrowed down using Boolean operators and an or and combination of words, which yielded about 278 studies. And then I added the word discharge guidelines or discharge protocol and narrowed them to 66 studies. These were reviewed through reading the abstracts for relevancy, and I narrowed down to 21 studies. The four main recurring themes were post-detoxification care, which some researchers called continuity of care, discharge planning, interventions to reduce readmission rates, and Alcoholics Anonymous. The study was guided by by Roger five-stage model, which constitutes of knowledge. There was knowledge educating the nurses, educating the managers about readmission rates and its implications. Persuading, because any new innovation is not easy, so persuasion is key because you have to convince people to drop what they're using and adopt what the change. So persuasion was used, decision, implementation, confirmation. These stages don't occur one by one. Some of them, are continuous. So after the completion, confirmation is done by the facility to decide whether the results fit their facility or not. Methodologies, chapter 3. This study, like I already mentioned, took place at Maryland Treatment Center, which is located in Rockville in Maryland. It's a 74-bed facility for residential and hospital detox and intermediate care services. The demographics of patients were varied. We had varying gender, varying ethnicities, varying socioeconomic status, but all of them were alcohol use disorder, and they were all above 18 years of age, 18 and older. The inclusion criteria was all participants for this project were admitted for alcohol detoxification, and the patients who were admitted for polysubstance use were included only if alcohol detoxification was one of the reasons for admission. All patients were 18 years and older. The facility only admits patients 18 years and older, which was easy for the researcher. No screening was necessary. Only patients who completed the alcohol detox and discharged by the provider were included, which means patients who left the program against medical advice were not counted. Patients who were not admitted for alcohol detox were not included. Patients who are admitted for detox from heroin, cocaine, or other illicit drugs without alcohol, they were not part of the study. This study used a pre and post intervention of design, comparing readmission rates before the intervention started and readmission rates after the discharge protocol, as will be explained later. The discharge guidelines were every patient who got discharged was educated about the importance of continuing with regular Alcoholic Anonymous attendance and was encouraged to follow up with the outpatient clinics. These were some of the data collection tools I used. On the right is a table. It was used for both pre and post. It shows the month 1, month 2 of implementation, month 3, and down here we see number of discharges and number of readmissions. So for each month I was getting the number of discharges and the number of readmissions, and then at the end I make the total. So for the pre-data, I used the 3 months before I started the implementation. We used the same tool. We're getting a number of patients who were discharged like in November before the implementation, and number of readmissions which were done in the same month. And on the other side, we see a validation tool which was mainly used by the nurses to indicate that every patient who got discharged, they were supposed to check off that the patient has been educated on continuing with AA attendance and continuing with outpatient attendance. So they would check off from this validation tool and drop it in the box which I provided. So at the end of the week, I would check in the box how many validation tools are there to know how many patients were discharged and if they were all educated. It was a self-administered tool on the part of the nurses, but it reminded the nurses that they had to do it. Below is this was a budget I drew before I started the research, but I ended up not spending much. For example, copy paper, I did not spend anything because the facility allowed me to use the stationery, stationery including cartridge, including computers, including office space. They were all provided. Initiation and initiation meetings, they were all inbuilt within the facility routine. So I did not spend on any of these meetings, which was great. Ethical considerations were followed during this project. The DNP, the student, I obtained approval from the DNP committee before implementation. Patients were not required to sign any piece of paper. No patient identifiers were collected, and there was no conflict of interest. Findings. I'll first highlight on the methods of evaluation just to give an idea on how this project was run. The project utilized the existing staff. This project did not develop any new discharge planning tool. It used the tools on site already in progress, but we just added one continuity of care aspect. It incorporated emphasis on continuity of care in the existing routine discharge guidelines. The normal routine of the facility was not interrupted or disrupted. Patients kept getting discharged as usual, apart from that addition. I obtained approval from the DNP and from the Maryland Treatment Center before implementation, held formal and informal meetings before implementations. These were done during the regular staff meetings at the end of the shift. Staff and management were sensitized about the upcoming project before it started, so everybody was excited about it. And they are excited waiting to hear the results, which will be disseminated, as we will see. Staff was trained, including the nurses, counselors, and providers and the managers, because we needed their support. Although I would like to point out that although the counselors and the nurses and providers were all instrumental in this project, they were not counted as participants for the project. I just wanted to point that out. Validity, the study utilized tools which have been validated through other studies, therefore the data was reliable. The facility has its own data bank, so even if I counted the number of discharges per month, I would still validate or check with the facility database to see that it matched. So having two collectors, it increased the reliability of the data. And all patients who got discharged received the same consistent and accurate information. The project used nurses who were trained on the purpose and objectives of the project to increase accuracy of the message that was given. And the data obtained from this project, therefore, was valid and reliable. This is a summary. Pre-data, like I said, we collected data before. That was the month of November 23, December 23, and January 24. And these were 157 discharges, and the readmissions were 36. So this gave a proportion of 36 and 57, 157. For post data, which was from February, March, and April, it gave a proportion of 35 to 159. Analysis. Data was analyzed using Excel computer program. And this statistic was used to compare the difference in two proportions. The study generated a power of 0.07, which was kind of considered low. The p-value was greater than the significance level of 0.05 with a value of 0.4 at 95% confidence interval, which implies no statistical significance. This is a table showing the pre and post data, just like I mentioned before. We can see the number of 35 over 159 and then 36 over 157, just like I mentioned earlier, pre and post data. This is also the same data displayed in a different way. For those who are visual, you can see the pre-intervention data and the post-intervention data. This is also the same data displayed in a bar chart, bar graph rather, where we have the brown and the small one is this is the post. On the right is the post intervention, and on the left is the pre-intervention. This is table 2, which mainly also from the z-test analysis, which brings out the p-value. Like I mentioned, it was 0.4. Just wanted to point that out. And table 3 mainly will show us the confidence interval and the z-statistic and the confidence lower and upper limits. And then I have table 4 showing the difference between two proportions. Here I wanted to point out the power. The power was 0.07, which was considered low. These are the results, like I already mentioned. The strengths of this project were many. It used a site with a large flow of clients. It was clear of any research misconduct because approval was obtained before implementation. It adhered to ethical regulations, including protecting patient information. There was no falsified information because the researcher was ahead of it. Would confirm the patient's discharge and count by herself. It utilized evidence-based methods. It used sample size, which was as advised by the statistician, actually went beyond over the 154 that was recommended, used the trained nurses throughout the study. So it had many benefits. Strengths. Other benefits of the study include improved quality of care, improved knowledge among the staff who took place in the, who were involved in the discharge and in the facility. Everybody wanted to know what is the use of this study. So it improved the knowledge among the staff, improved understanding among staff about importance of readmission rates. The nurses verbalized learning a lot from the project. It also improved knowledge for the part of the researcher who spent hours and hours researching and up to this time still researching about the same topic. So it improved knowledge and understanding about this topic. Some of the facilitators were, the project went smoothly as planned. Once implementation started, there was nothing like stopping or any obstacles. No obstacles were met. The Maryville statistician was very crucial. My chair, Dr. Stewart, was very crucial in guiding the project. These were all facilitators for the project. Some of the limitations, even if I adhered to the said sample size, the study yielded low power. So probably a little bigger sample size would have been better. and also varied population. You know, these are alcohol, some are mixed use disorders. It could have interfered with the outcomes. And also these variabilities may also interfere with generalizability, issues of generalizability, and the short duration of 3 months probably would have realized better, could have compromised on the outcomes of the study. Implications to nursing, like I already mentioned, the study improved nursing knowledge. Nurses appreciated the role of discharge teaching in linking patients to the communities. The study contributes to facilities database for future reference. Future research, this study revealed gaps in what is missing. So future studies can build on this study to make it better. Uh, it's also a base for other quality improvement projects. Future studies should consider using larger sample size to improve on generalizability and improve on the power. Future studies should consider longer than 3 months, like I already mentioned. I recommend that the revised discharge guidelines be incorporated into the routine of the facility, like I will tell them during dissemination. Future studies should also consider using multi-substance guideline discharge instead of focusing on alcohol only. The results of this study and implications will be shared with the facility staff and management. The scholar will appreciate the opportunity to conduct the study in the facility, will appreciate the staff effort in making this project a success. The scholar will remind the staff that they have a crucial role in bridging the gap between the facility and the communities. And the management will be encouraged to continue with the effort to reduce readmission rates. Management will also be encouraged to continue supporting future researchers to build knowledge. It is the scholars' hope that the results of this study will contribute to future research, not only at Maryland Treatment Center, but in other detox facilities. The scholar is very grateful to Maryville University for the guidance and support, and very grateful to Maryland Treatment Center. Thank you for listening to my presentation, and these are my references. Thank you.